Okay, here's our second day of case studies. We're going to do lymphedema, burn case study, and a neuropathic or diabetic ulcer. So we're going to start out with the lymphedema case study. So Miss BP is a 46-year-old female, was diagnosed with breast cancer in 1995 and underwent a right mastectomy with reconstruction in August of 1995. This was followed by radiation in March of 1996 and chemotherapy from April 1995 to February 1996. She reports a sudden onset of swelling in her right arm and hand in 1997. She was diagnosed with lymphedema at that time. What's really important about this to recognize is that 2 years after the surgery and 1 year after the radiation, she developed the lymphedema. So lymphedema is not something that necessarily has a sudden onset. It can often come on a couple of years after. It could come on after traveling, when there's a pressure change. It can come on after an infection. It can come on just because of stress. Let's say that she'd had no problems whatsoever in her right arm, but let's say she moved, and because she was picking up boxes or carrying boxes during her move, that can start a flare of lymphedema that she'd never had before. So in this case, this is typical of a delayed onset of lymphedema, which is something that the patient really needs to be educated about at the time of the surgery. All right, so in the past she had manual lymphatic drainage and congestive therapy, compression sleeves and gauntlets, and she had taken a drug which she had gotten from Mexico because it is not approved in the United States by the FDA, but there's some information out there that it can decrease lymphedema. It's not been proven. Okay, so then she was never set up with a home maintenance program except a bandage night and wear compression sleeve and gauntlet in the daytime. So they didn't give her any exercises, didn't show her, any manual lymphatic drainage, basically just gave her the bandaging and the compression sleeve. So she went to see her physician for treatment of a cold, but was seen by an associate physician due to her physician's absence that day. This physician noted the patient's apparent lymphedema and asked if she had ever been treated for it. The patient stated that she had in the past, but found it impossible to bandage her right arm since she's right-handed. She lives alone and has no one who can bandage for her every night. Subsequently, every summer she experiences an exacerbation, repeats manual lymphatic drainage, and that each year it has become more difficult to reduce the edema. She is referred currently for treatment. So let's talk a little bit about this and why it happened. She was discharged, as I said, without being taught any manual lymphatic drainage, and was told to bandage, but she's right-handed, lived alone, and couldn't bandage herself. So she, each summer when there's heat, when there's, so extreme heat, as you know, will cause swelling. So during the summer, when people are generally more active and the temperature is higher, she would experience an exacerbation, which is not uncommon. However, with each time that she had this exacerbation, it says it's become more difficult to reduce the edema. So each time there's damage and scar tissue that is happening with the edema or the lymphedema, there's damage to the skin itself until the lymphedema can be decreased. But it's taking a longer and longer period of time, so you're really creating more damage to the skin and more scar tissue. So on observation, the right hand and arm are visibly larger than the left. The edema volume chart showed 24.7% increase in volume in the affected limb. The back of her right hand was extremely edematous. but was soft, which is really important because had it been hard, we would know that edema had changed, made some changes. Not only was it a more significant edema, and as we know, a different level of lymphedema, but also there will be more significant changes to the skin itself. So it also goes on to say areas of hardened tissue can be palpated in the right lower arm, just distal to the antecubital space. So obviously there are areas where the tissue is hard, there's an advanced stage of lymphedema, and there's changes to the skin itself due to lack of nutrition relating to the lymphedema. Also says the edema was greater in the lower than the upper arm. The skin was warm, dry, and intact with no signs or symptoms of infection. So the edema being greater in the lower than the upper arm means that she was having more proximal drainage. So the lymphatic system was draining better proximally than it was distally, which is as usual the case. The patient was described manual lymphatic drainage and congestive therapy times 20 treatments daily, times 20 treatments. During this time, she was self-taught manual lymphatic drainage, skin care, breathing, and arm exercises. The importance of the breathing, as we talked about, is the pump, especially because we're talking upper extremity. We're talking about the respiratory pump that causes it causes the lymphatic system to work in a more appropriate manner because you're talking about a pressure gradient change with a respiratory pump. So it's important for the patient to understand that component of decongestive therapy. Also the gentle arm exercises to get the muscle pump. So you've got the respiratory pump going, you've taught her the respiratory pump, you've taught her the muscle pump, we've taught her the manual lymphatic drainage, and then in general skin care, like avoiding, keeping the area clean, avoiding any cuts or infections, what to do if you do see a cut or infection, what you have to do immediately is to get a topical antimicrobial or ointment on it, and to decrease the body's reaction. And so all of this is really important information to keep her, once we get her decongest, to keep her arm at that level. So she was also prescribed and provided with a LymphoPress compression pump, a reed sleeve Optiflow insert to be worn under the pump sleeve during pumping time to continue to stimulate the lymphatic system and to keep the collateral pathways open. The reed sleeve was substituted for compression bandaging at night since the patient had admitted to not being able to comply with this part of her treatment after prior MLD therapies. So what's happened here is that you've taken into account the fact that the patient is right-handed, lives alone, and can't do her own compression wrap. So we've gotten her a compression garment called a reed sleeve. She also has a compression pump that she can use to stimulate the lymphatic system on a regular basis. So the combination of the pump, the external pump, and then the reed sleeve at night should stimulate decompression, and then the compression garment should keep her decompressed. So the results are she responded very well to her manual lymphatic drainage and decongestive therapy. After 5 treatments, her edema chart revealed a 70.6% reduction of volume in her right arm. Her hand continued to be puffy and edematous, so intensive work was done proximally in the wrist and the hand. At the end of the 9th treatment, it was apparent that her right arm and hand had continued to reduce but her hand was still not responding as well. She received her reed sleeve that day and wore it at bedtime in lieu of the bandages. When she returned for her 10th treatment, her hand had visibly gone down to almost normal size. The patient was thrilled not only with the results, but the convenience of the reed sleeve as opposed to bandaging. When measured, her edema volume chart revealed a 97.8% reduction in volume in her right arm. The last 2 weeks of manual lymphatic drainage therapy, the patient chose not to continue bandaging, but rather to follow her home maintenance program to help her to incorporate them into her activities of daily living. She finished her 20 treatments at the end of her manual lymphatic drainage therapy. She had 91% overall reduction of volume. The increase is attributable to the fact that during this time the patient was wearing an old ill-fitting compression sleeve and gauntlet, which is the hand component of it. However, by the time she was discharged, the patient had new, well-fitted compression garments. So the follow-up is that she's thrilled with her results and also her home program. Loves the pump and the reed sleeve insert, and finds this time that she's on the pump very relaxing. She wears the reed sleeve all night and even takes it to the office sometimes with her to wear while she's sitting in meetings. Very pleased with her compression garments and feels that the new compression garments, because remember it said that she had old compression garments. That's the other thing that I need to make sure you guys understand. Compression garments must be replaced every 6 months. So that's a big problem with patients with lymphedema, is if they're not replacing the compression garment every month, every 6 months, the compression garment loses its effectiveness. So that was the case in this particular case study. So her compression garments were replaced, and she feels she likes the way they fit. They have a much better appearance. So she's been able to return to her full-time position with the large city library system, and she now has hope and feels empowered to care for her lymphedema at home. So by making a few changes in her home program, and also taking into account that the lady lives alone and what she functionally could do because it's on her right arm and she's right-handed, you got a better result. So the important parts are to take into account here is the treatment conformed to a plan of care that she could be compliant with, so such as the reed sleeve versus the compression bandaging. Also, the gains and the reductions were made with manual lymphatic drainage and were followed with new compression garments to make sure that she maintained those gains, which made her feel more successful and didn't give her this repeat, I'm going to be back every summer because my swelling has gotten bad again. So that makes a patient with lymphedema, much more willing to follow the program when they know that it is successful and can maintain their own decrease in edema. All right, case study 2 is our neuropathic ulcer. So FJ is 65 years old and lives alone. He has poor vision and limited mobility because his hips are painful. He was diagnosed with type 2 diabetes 3 years ago and has been poorly maintained on oral hypoglycemics since then. Intermittently attends his local diabetic clinic, and during his last visit it was discovered that Fred had an ulcer at the base of his right big toe. He had been treating the wound himself for 3 months by bathing it in salt and water. So on initial assessment, he had a large necrotic wound at the base of his right big toe. The wound was painless and dry, and the skin at the base of the toe was red. So the next one is a picture. Here's a picture of what the wound looks like. You can see the red area that was discussed. You can see the wound itself. If you had to do a red, yellow, black on this, you would say that it is probably about 50-60% black. There's maybe 20% or 30% yellow, and then what does that leave us? 10% red. There's just a little bit of red on the outer edge of it. So this is in significant need of some debridement. Also, the redness shows that he is an active infection, so we need to inflammatory process. So we need to get that eschar off of there and clean up that wound bed and see how deep it goes. So the problem list is uncontrolled blood sugars, inconsistent medical care, because it said he came inconsistently to the diabetes clinic. He has the wound on the bottom of his great toe with necrotic tissue. He has inappropriate footwear, obviously, because he has this wound on the bottom of his great toe, and he has inadequate wound treatment in that he's been treating it with salt and water. Now, one of the things that I caught as I was reading you the history that I didn't put on this problem list is it also said that he doesn't walk very well, so there's significant mobility issues. So that needed to be put on the problem list as well. So the interventions and referrals are medical management and regular nursing care for blood sugar management and medication management. He really needs some education because it's obvious from the history he doesn't know how to keep himself healthy with his diagnosis of diabetes. It's been what I think said 3 years, 2 or 3 years, but he's never really been taught on a regular basis how to take care of himself. So that would be really important to get for this gentleman, whether it's home visiting nurses or whether he comes into a clinic every day. There's got to be some kind of consistency so that he begins to demonstrate this knowledge to maintain his health with diabetes. So next, wound care, including sharp debridement and enzymatic debridement. Due to the dryness of the wound, we want to use an enzymatic topical, would probably be most effective because it is a very dry wound, to get rid of the necrotic tissue. We'd also most likely with putting the enzymatic topical on it would soften it enough that we could do some sharp debridement and speed up the debridement of that eschar and hopefully get to granulation tissue or to a nice beefy red wound bed underneath. However, we don't know how deep it is because it's covered with eschar. So it'd be important to get that off and make sure it's not going to the bone and we don't have a risk of osteomyelitis. Next, we want to do some total contact casting to offload the great toe while the wound is healing. We've already identified that he's non-compliant, so putting a total contact cast on him for a period of time would allow us to be most compliant with it. So the total contact cast we could leave on for 5 to 7 days. And then we could bivalve it, take it off, bivalve it, see what the wound looks like, clean it up a little bit, and then put it back on by bivalving the total contact cast. You can then wrap it back onto the wound if we feel like we need to offload him for even longer. We also want to refer him to the nutritionist for dietary education and management because obviously he's not, again, hasn't had the extensive education he needs with the diabetes diagnosis. And we also want to get him to an endocrinologist for some better diabetic management. Also, we want to refer him to a pet orthotist because he is going to have a custom shoe. Once we get rid of that total contact cast, he's going to have a custom shoe for that foot. All right, case study number 3 is the burn case study. So this is an 11-month-old baby girl, was healthy and normally developed prior to this trauma incident. On examination, she'd had all of her required vaccinations and had no previous trauma history. At the time of the accident, the baby was able to stand with assist, but was not yet walking unassisted because she is 11 months old. So she was admitted to the pediatric burn unit after hot coffee spilt over her face, neck, shoulder, forearms, and chest in an unsuspicious domestic accident. The burns occurred approximately 30 minutes prior to admission. The child had managed to pull herself up to a work surface and reached up and grabbed a cup of coffee that the mom thought was out of the child's reach, and that's how she spilled it on herself and burned herself. The coffee had been made with boiling water a few minutes before the accident occurred. The child pulled the cup over herself, and approximately 1/3 of the contents spilled over the child's face and upper torso. The mother covered the burns with a cold cloth almost immediately after the accident and then called an ambulance. On admission, the burns were cleaned with normal saline solution and then assessed for depth and area. And this is a picture of the burns. You can see them on the neck, the lower jaw, the upper chest area, and then on the right arm around the shoulder and the deltoid area, and biceps area, upper biceps area. Also, I want to point out in this picture that you can see white eschar covering some of the wound, but then you can also see some pink around the white eschar. So our problem list for this baby is a full thickness burn wounds with white eschar. We have a risk of contracture of the neck, the chest, and the right arm. Also a risk of dehydration and infection, and significant pain. The interventions and referrals. So interventions and referrals, we want to do dressing changes 2 to 3 times a day with an antimicrobial topical to soften and debride the eschar, and then also to maintain the moisture level to promote healing. We also want to consider Whirlpool. Of course, we would only submerge her to her chest, but we really want to promote cleansing and then get some range of motion of her neck and her right shoulder to keep the skin moving as it's healing, to make sure we're not going to get contractures of her neck or that shoulder, that right shoulder or arm. We also want to refer to a nutritionist for dietary changes to promote healing. Since she's only 11 months old, it's not quite, it wasn't said what she's eating, but we want to make sure that she is getting the increased nutrition, because remember we talked about with burns, there's an increased energy expenditure in the body that's trying to heal. So we need to make sure that she gets that increase in calories, she gets the increase in protein, and all the vitamins that she needs to promote healing. We want to do a referral to pain management. At an 11-month-old, it's going to have a really hard time understanding this, and so want to make sure that we're doing everything we can do to give her the most pain management we can do, and then also refer and fit her for an upper body compression garment, because when she gets to the level where we've actually finally debrided that eschar and got her to start healing, then she's gonna need a compression garment to decrease the scarring, and also because she has darker skin, we're going to want to make sure there's no keloid formation or any other kind of abnormal scar tissue. So keeping her in a compression garment upper body compression garment is going to be really important. So that's it for all of the case studies. Please email me any questions you have about any of these case studies. If there's anything that I missed that I didn't say and you catch it, please let me know. Because it's important. I want to give you guys basics. I want you to think about, as you're reading these case studies, I want you to think about what your problem list would be and what your intervention it would be, and I want you to think not only about the wound but everything else. Think about equipment or garments or shoes or any of the other things. And then also think about tailoring the plan of care directly to the patient so that you know that it can be successful, because that's the important part of providing a successful intervention. I have enjoyed being with you guys. I hope that if you have any questions between now and the time you have the final exam, that you will please email me. I emailed the gentleman today about Moodle to try to figure out how to open up that forum so we can have that open forum for review. So, and hopefully I'll have the details on how to get that done within the next week. So tomorrow you have open time to do your EBP project. Dr. Risley did share with me that she's extended the deadline, which is fantastic. Again, if you guys have any questions or having any troubles, please email me and I will get back to you immediately. But good luck, and it's been wonderful being with you this semester. Take care.